Hi friends, in today's clinic we will learn the examination of the ear. This examination of the ear can be divided into two parts, the physical examination and the functional examination. In the physical examination, we will be examining the ear, its surrounding region, external canal, the tympanic membrane, middle ear structures, middle ear cleft, masseter bone, eustachian tube. Whereas in functional examination, we will be examining the auditory functions and the functions of the balance. So today I will be showing you the correct technique of the physical examination of the ear. In the pinna, we should see for any swelling. In the physical examination, as I was telling you, we will examine this pinna, we will examine the surrounding area, this is the pre-auricular region, this is the post-auricular region, and first let us begin with the pinna. So in pinna, first we should identify all the landmarks that we can see, all the projections and depressions. So this is the region of the helix, this is the crest of the helix, and this is the most common site for the pre-auricular sinus. This is antihelix. You can see this antihelix divided into two. This region is called the scaphoid fossa, and this is the triangular fossa. This one, this is scaphoid fossa, and this is the Simba region, where we feel the elicit tenderness for the masteritis. And this is the concha part, and here will begin the external canal. This is tragus, antitragus, and intertragus nodes. And this you can see this Darwin tubercle. So these all these structures we can identify. And then usually the hematoma swelling that occurs here, and that is smooth and painless. Whereas swelling of the periconditis region, that will be very painful and little and say it is if it's burst open, a little pressure that will lead to oozing of the purulent fluid. And then we should see for the post-auricular region. In the post-auricular region, we should see for this sulcus, we can see, and then you can see this post-auricular region. Mainly this is the mastoid region that we can see, and we should usually the surface of this mastoid is irregular, it's not smooth, but in cases of periostitis or it will get smooth. And this retroauricular sulcus, usually it's well defined and well nicely seen, but in cases of furuncle of the external canal, it can get obliterated. Whereas in cases of mastoid abscess, it will remain intact. And we should see for the position of the pinna also, that is important, because in cases of mastoid abscess, this pinna will get it will be shifted towards laterally little and anteriorly. Whereas in cases of mastoid abscess, it will move little inferiorly. And we should see for any scar, because the tympanoplasty surgery is very common. We should see for any swelling. We should see for any fistula, because in cases of cholesteatoma, the mastoid abscess can occur and that can burst open, and if it is not treated, then that will act as that will lead to the fistula. So all these things we should see here, and then will come the examination of the external ear, the external aortic canal. For examining the external aortic canal, we should see for any swelling of the external aortic canal. We should see for any discharge or any wax is there, fungus is there, any foreign body is there. So if any structure that is in the external canal, that we should note. And before examining the tympanic membrane, we will have to remove these structures, because then only we will be able to see the tympanic membrane. And for examining the external canal and tympanic membrane, we have to retract the pinna. So this retraction is very important. With one hand, the tragus is retracted anteriorly, and with the other hand, the pinna is retracted superiorly, posteriorly, and laterally. And then we should try to see the tympanic membrane. Now I will try to focus and show you the tympanic membrane. I think you can see this shining grayish white structure, that is the tympanic membrane. You can see the handle of malleus. You can see the little process of the malleus. You can see the cone of light. So in the majority of the cases, if you retract the pinna properly, we can see the entire external aortic canal, and we can see even the tympanic membrane. There is no need for any even speculum. The ear speculum. So with the help of speculum also we can examine the tympanic membrane and the external aortic canal. So before inserting this auricle, speculum, again we will have to retract the pinna. So after retracting the pinna, then we should introduce this. And this size is very important. Light. The size is very important. Size of the speculum, the largest possible size that can go easily into the external aortic canal, that we should select. Yes. Now you can see this shining structure, that is the cone of light. You can see the handle of the malleus. You can see this membrana tensa and flaccida. Umbo, you can see the little process of the malleus, that also you can see. So you can see all these different parts of the tympanic membrane. So when we are examining the external aortic canal, we should see the wall of the external aortic canal, whether there is any swelling or not, because the most common swelling in this part is the furuncle, and this furuncle, it occurs always in the external cartilaginous part of the external aortic canal, because the bony part of the external aortic canal, it doesn't have the hair follicles. So hairy follicles, they are situated only in the outer cartilaginous parts. It's a very common condition. So if the furuncle is there, then even the movement of the pinna, if we move the pinna like this, that will become painful. Even if we push the tragus, even that also will become painful. And even that I was telling, this retroauricular sulcus also, that we get retroauricular sulcus, you can see that will also get a little obliterated in cases of furuncle of the external aortic canal. So the furuncle is very, you can really see the tenderness also. You can really see the local temperature, raised local temperature. So all the signs and symptoms of the acute infection, they will be there. And once it bursts open, then patient will have ear discharge and the pain will subside. Then other common conditions of the external aortic canal are this ear wax, if it is there. If it is too much, then it will not allow us to see the tympanic membrane. Any foreign body is there, that we should notice and we will have to remove. Any discharge, any bleeding, so that also we should note. And then we can see even the tympanic membrane. So in the tympanic membrane, we should see for its color. Normal tympanic membrane is like a shining pearly white semi-transparent structure. But if it becomes a certain condition, it can become dull. And in some conditions, it can become even red and congested. The most common cause in which the tympanic membrane will become red and congested is the acute otitis media. And then, in cases of secretory otitis media, tympanic membrane may look like little dull in color, or umber color, little yellowish tints that we can see. And in cases of hemotympanum, the tympanic membrane will look little bluish in color. So this color discoloration, that also we should notice. And then we should see for any perforation. So for the perforation, we can divide the perforation roughly into 4 categories: the small perforation, medium perforation, large perforation, and the subtotal and the total loss. So this we can say that we can divide this tympanic membrana tensa into 4 quadrants: antero-superior, antero-inferior, posterior-superior, and posterior-inferior. So if the perforation is covering only one quadrant, that will be called the small perforation. If it is covering the two quadrants, then that is called medium size perforation. If the 3, then we can call it large perforation. And if it is involving all the 4 quadrants, then we can see it subtotal. In subtotal, all the 4 quadrants will be involved. And in total perforation, even tympanic annulus also that will be involved. So if the tympanic annulus is not involved, all those perforation they are called central perforation. And as you must be aware that this central perforation is present only in safe type of chronic subotitis media. Whereas in unsafe type of otitis CSOM, there will be cholecystoma and the perforation will be marginal perforation. It is called marginal perforation because the tympanic annulus that is eroded, that is absent, that is involved in the disease. That's why it is called marginal perforation. So that we will be able to, we should be able to see. And sometimes the tympanic membrane is very thin. It's almost transparent. So in those cases we can see the structures of the middle ear, like this incudostapedial joint we can see, eustachian tube opening we can see the round window, and even sometimes the long process of the incus, that also we can see. And sometimes if the perforation is very large, in cases of subtotal perforation, again we can see the middle ear structures, like this middle ear mucosa we can see, ossicles, this incudostapedial joint, long process of the incus that we can see, opening of the eustachian tube that we can see, again the round window we can see. Then the condition of the middle ear mucosa, that also we should notice. If it is congested, it means disease is active. As you know, we can divide this chronic subotitis media safe type into 4 active disease. In active disease we can see the continuous discharge. Inactive disease, the discharge will not be there. In the dry ear again the discharge will not be there. And after some time the disease can get healed also. The perforation that has occurred, that can heal, and that is called healed otitis media. So that perforation that heals, that at that site the tympanic membrane will be very transparent, very thin, and through that also we can see the structure. And in these patients they should take precaution. They should not blow the nose, because too much blowing of the nose can again perforate this thin part of the tympanic membrane. So all these structures, all the things we can see if there is big perforation of the tympanic membrane, or if there is and then we should see during this our examination the tympanic membrane, whether it is retracted or it is in normal position or it is little bulging. The bulging of the tympanic membrane occurs in cases of acute otitis media, and in case if there is any tumor of the middle ear, that also can lead to bulging. And then it can get retracted also. If there is eustachian tube is obstructed, then that can lead to generalized retraction of the tympanic membrane. So with the generalized retraction of the tympanic membrane, there are certain features on the basis of which we can say that the tympanic membrane is retracted. Like this cone of light, it will get blood or it can be even absent also. Then the long process of the malleus, it looks apparently shortened. There is no shortening, because when tympanic membrane is normal, it is straight, and when it is retracted, it will look like this. So that will lead to apparent shortening of the long process of the malleus. And then we can see the the little process of the malleus that will become prominent, and the anterior and posterior mallear folds, they also become very, very prominent. And then on sigillization, this tympanic membrane will not move if it is retracted. So there is restricted movement of the tympanic membrane. Again, that will tell us that the tympanic membrane is retracted. So the most common, then we can see sometimes the retraction pockets. In general retraction, there is no retraction pocket, but in some cases we can see the retraction pocket. The most common site of the retraction pocket is the posterior superior quadrant of the tympanic membrane. So that is the most common site of the retraction pocket, the posterior superior quadrant of the tympanic membrane. And if it is not treated in time, it can lead to this unsafe type of chronic subotitis media with cholecystoma. Because in this deep pocket, what will happen? The discriminated skin that will get collected, and that will not be removed, and gradually it increases in size, it gets infected, and that can lead to the formation of the cholecystoma, and that can lead to this unsafe type of chronic suppurative otitis media. Then we should see for any cholecystoma. As I told you, it's the part of this unsafe type of dangerous type of CSOM. You can see sometimes this whitish flecks of this cholecystoma in the middle ear or in the external canal. Then we should see for any granulations. These granulations we can see in cases of safe as well as in cases of unsafe type of CSM. In unsafe type of CSM, the most common site for the granulations are the posterior superior meatal wall or posterior superior quadrant, you can say, of the tympanic membrane. And in safe type, we can see sometimes in the central perforation, the margins, on the margins we can see the granulations, or we can see the granulations on the outer surface of the tympanic membrane. So that we should notice. See for any polyp, because again it's a very common condition. So this polyp, it can occur in cases of both the types of CSM. It can occur in safe as well as in the unsafe type of CSM. In the safe type of CSM polyp, it looks little dull in color and it won't bleed, and it is not friable. Whereas in cases of unsafe type of CSM, it will be fleshy mass and very vascular, and it can bleed also if it is handled roughly. So that polyp also that we should see. But usually we should, if the polyp is there, we should consider the disease as unsafe type, because after removing the polyp, then we can see whether the disease is, whether the patient is having cholesterol, whether it is safe type or unsafe type of CSM. Now we'll see the functioning of the facial nerve, because the facial nerve also it is to be examined in cases of ear diseases. So now I will demonstrate you how to examine the facial nerve. So we ask the patient to see toward the ceiling. So if the patient is looking toward the ceiling, we can see this forehead furrows. Okay, you can see this forehead furrows. So on the side of facial palsy, patient will not be able to make these forehead furrows. Then we ask the patient to close eyes. So on the paralyzed side, patient will not be able to close the eyes. Show your teeth. On the paralyzed side, this angle of mouth, it will not move. Blow your cheek. On the paralyzed side, this blowing of cheek will lead to this leakage of air from here, this side. And move the platysma. This movement, platysma movement, you can ask the patient to perform. Sometimes it's difficult, but we can try at least. So in these 4-5 movements, we can know whether the facial nerve is functioning or not. So in this session, we learned how to perform examination of the ear. Mainly we discussed the examination of the pinna and its surrounding region, pre-auricular region, post-auricular region discussed, and the examination of the external canal, tympanic membrane. Now in the next session, we will talk about the otoscopy examination, the facial nerve examination, and then hearing test, auditory evaluation, and the vestibular test. Thank you.